Thank you, Chantal. Just like to thank the organizers for inviting us to be a part of your very esteemed meeting. When I started preparing my talk, I went into precision medicine, meaning I looked at proteomics, metabolomics, I looked at biomarkers, phenotypes, etc. And then something got me thinking, and I said, you know, this is not personalized medicine. Personalized medicine is where I'd like to get the medicine into the target organ in that particular patient who has multiple comorbidities, who is older, who cannot use the medication properly, because the majority of the medication in COPD and perhaps in asthma as well is via an inhaled route. All of us know how to swallow pills, and we believe that all of us know how to use inhaler therapy. And I've decided to therefore change to inhaler devices. And it may sound like a very mundane topic, but I think it's very, very, very important. And this was brought home by a very nice study, and one of the main co-authors in this study is sitting in the audience, which was published earlier this year in the ERJ. And it looked at chronic obstructive pulmonary disease, exacerbation and inhaler device handling, real life assessment of close to 3,000 patients done in France. And it included 212 GPs, 50 pulmonologists, as I said, close to 3,000 patients. There were handling errors in over 50% of patients, and critical errors, 15% with the breathehailer, 21% with the discus, close to 30% with the handyhaler, 44% with the PMDI, and 47% with the turbuhaler, a respimat, and 32% with the turbuhaler. Did this affect control? Yes. Patients with critical errors had twice the number of exacerbations, so it does impact on control. And what was the problems? I mean, I don't want you to read the whole slide, but these were there were either problems with dose preparation, dose delivery. And with the different devices, there were different problems. Obviously, with the PMDI, mainly synchronization. With the other devices, it was loading or using a device without loading it, etc. And there's a very nice accompanying editorial, and I've decided to cut and paste what the author wrote about problems with inhaler devices in general. As I said, over 50% of COPD patients are not able to use their devices correctly, and I suspect it's even higher than that. And that those making critical errors are twice as likely to have a severe exacerbation as compared to those who do not make critical errors. And this finding is similar to asthma studies. And what the sobering thought is that despite advancement in so-called precision medicine, in medication in general over the last 50 years, there has been no change in our ability or our patients' ability to use inhaler devices correctly. And what is the reason for this? So this is put very nicely by the author, where he states that the next question is, do healthcare providers lack awareness, knowledge, or motivation to solve the problem? Is it reasonable to say that when it comes to awareness and tools, we are not lacking? In fact, Gina and Gold collectively mentioned inhaler technique over 70 times. When it comes to tools, there's an abundance. I mean, there's international and local organizations, manufacturers providing websites, resources, and tools to help us train our patients. Therefore, while lack of awareness and availability of tools are not the problem, healthcare provider knowledge and skills are most certainly the problem. In other words, we don't know how to use our device or the devices properly, so how do we teach our patients? And it's often because we don't think inhaler technique is important. So this is a very nice task force report by the ERS, published in the ERJ 2011. And there's a few important aspects I'd like to highlight. That is, firstly, the labeled dose or the nominal dose. And this is the dose that's available from the aerosol per actuation. So how much does the aerosol actually meter out? And then there's the TED, or the total emitted dose. And this is how much of that dose per actuation that is actually available for inhalation. Then the fine particle dose is a mass of particles less than 5 microns in size within the total dose. And then there's a fine particle fraction, which is the fine particle dose over the total dose emitted. So that's the fraction of fine particles. And the other important concept, which I'll mention later, is the mass median aerodynamic diameter, or the MMAD. And the MMAD divides the aerosol size distribution perfectly in half. In other words, what diameter determines which, at which 50% of the particles are larger and 50% smaller. Why is that important? This is the log aerodynamic diameter on the x-axis, and that's the deposition. Smaller particles will deposit mainly alveoli, and as it gets slightly bigger, bronchial and conducting airways, and the large particles are all deposited in the oropharynx. So the recommendations from the task force is that all prescribers should know the type of devices, the specific drugs in those devices, and the classes of drugs. They should appreciate the advantages and disadvantages of each device. Choose devices that the patient can and will use effectively. So the patient is an important part of this whole process. Obviously, we can't use devices that are not approved. We have to train patients the correct maneuver. Check the technique regularly and review patients' adherence to treatment. Do not switch to a new device without the patient's involvement. And a very important concept which we forget, and this is especially important in PMDIs, I believe, and that is inspiratory flow. And this is ignored largely, and it's very, very important in severe COPD, where they cannot generate very good inspiratory flow. And different devices require different inspiratory flows for effective delivery to the lungs. And the task force divides it into patients who have good coordination and poor coordination, and further into inspiratory flow greater than 30 or less than 30 on each side. So if they have good coordination, all right, between hand and inhalation, with very good inspiratory flow, you can use any device. Okay, that's an ideal patient. But many of our patients may have good coordination but poor inspiratory flow, less than 30 liters per minute. You could use the PMDI or a nebulizer, but the DPI will not work in those patients. Okay, so many of our severe COPD patients, we can't use DPIs. With patients who have poor coordination, all right, you would then, excuse me, in all of them, you wouldn't use a PMDI. Could use PMDI and spacer, whether they have good or poor inspiratory flow. Good flow, you could use a DPI or a nebulizer. But if they have poor coordination with poor inspiratory flow, you could use either a nebulizer or a PMDI and spacer. And many of our patients would fall into that category. Many of our COPD patients. So what are the factors that affect lung deposition? The size of the particle, inspiratory flow, integrity of the airway, proper inhaler device. And one other point that's missing here is the velocity of the medication as it comes out of the delivery device. Fine particle fraction is a percentage of the aerosol between 1 to 5 microns. And like I showed you earlier on, the importance is the bigger particles will be deposited in the mouth and oropharynx. 5 to 10 microns will be mainly in the first 6 generations of airways, and less than 5 will be in the last 5 to 6 generations. So the fine particles go deeper into the lungs. And as I said, the MMAD, which is the mass median airway diameter, is a calculated diameter that divides the particles into half based on the weight. And so what does 5 microns, MMAD of 5 microns means 50% will be less than 5 and 50% greater than 5. Now look at the different devices and molecules. Depending on the mass median airway diameter, you can see the deposition increases with smaller particles, the lung deposition. So a fluticasone DPI MMAD is 15% lung deposition, as opposed to HFA particles, cyclosinide solution, 1 MMAD of 52% of lung deposition. So it's an important aspect to consider with the inhaler device. I've just listed for you the variable inhaler devices, the PMDI, and remember, the other very important aspect is the speed of inhalation. If a patient uses a PMDI with fast inhalation, most of the particles deposit at the back of the throat. And that's why they get increased systemic bioavailability, side effects, and poor efficacy of the drug. It's not going to get to where it's supposed to. So a slow inhalation with the PMDI is vitally important, okay? And that's something I've found many patients are not taught. Whereas with the DPI requires a critical flow to disaggregate and disperse the powder. So you've got to have a critical flow to break up the particle from the actual constitution within the device. And if the flow is not above a certain level, you obviously don't get good lung deposition, and you don't get a good fine particle fraction. And the soft mist inhaler, provides a nice, it's almost like a nebulizer, because it provides a slow, more uniform and a fine mist, less coordination required, a long plume duration, longer than a PMDI, but the loading of the device, of the dose into the device, sometimes confuses patients. Nebulizers I'm not going to say much about. Okay, and as you know, there's various devices, your PMDI, then you have the PMDI with the spacer, PMDI with the spacer with tidal breathing, AccuHaler, Aerolyzer, Autohaler, BreezeHaler, the Ellipta device, Genuair, HandyHaler, RespiMat, and TurboHaler. These are all your DPIs. Okay, I'm not going to go into this in detail, and that's just instructions on how to use the PMDI, the breath-actuated MDI, and I'd refer you again to the task force, the ERJ ISAM task force report. Similarly with all the other devices. Okay. Remember, the MDI or PMDI with the spacer device you would use in patients who have poor coordination, and many of our older patients do have that problem. You get reduced oropharyngeal deposition. It increases the inhaled drug by 2 to 4 times and allows use of the PMDI even during an acute exacerbation. No drug preparation required, and it simplifies the coordination. The disadvantage is obviously it's a large and cumbersome device, it's expensive and bulky, you need assembly, and patient errors in firing multiple puffs into the chamber, and possible contamination with inadequate cleaning. Or just one other thing in passing is the CFC versus HFA. The MDIs, the spacer devices were developed for CFC containing formulations. The HFA two things. One, you don't need to shake, okay, because it's fine particles. It's not held together with a propellant, and it's evenly distributed throughout the plume. Whereas with the CFC, you do need to shake it to distribute it evenly so you get the same drug delivery. Okay, and like I've said, you get better deposition into the lungs with a spacer device. Okay, these are, again, just a repetition. Turbuhaler. Remember, powder de-agglomeration principle is very important with the turbuhaler, and you need an optimal inspiratory flow, probably close to 60 liters per minute rather than less than that. And the accuhaler. And the DPI inhaler performance, remember the intrinsic resistance of the device is also relatively important. Some of them have a higher intrinsic resistance than others. Okay, so the inspiratory flow range of DPIs, the accuhaler discus, here's the flow range. At 30, 40 liters of inspiratory flow works pretty well. Turbuhaler, you need 60. As much as the manufacturers will say you have delivery from 30 liter inspiratory flow, optimal delivery occurs at an inspiratory flow of 60 or more. Autohaler, probably about 30, and the easy breathe Surehaler, even lower inspiratory flow required for optimal delivery. And the flow rate also determines your fine particle fraction. If you look at your flow rate here versus fine particle with each of the devices, the turbuhaler device, you can see your fine particle fraction is probably optimal at 60 or above. You get, a higher level of deposition, whereas with the dischaler device, fine particle, you can get it from about 30 up. Then the other devices mentioned there as well, the Novalizer device as well, which is the triangles. I think I'll just skip this because I'm sure you're all quite familiar. And then just briefly, drug deposition from various inhalers. You got the PMDI with spacer, and the deposition in the lungs in blue, and you can see the PMDI with a non-electrostatic spacer probably has in this study the best delivery, but it doesn't include some of the newer devices. Okay, and the other important aspect which we forget is that most of our COPD patients are older. Okay, and the specific problems with the elderly in terms of inhaler use. Inadequate coordination. They may have poor fine motor control. They may have weakness from arthritis or stroke. Challenges with DPI, difficulty opening the medication blister pack. So importantly, we must ask the patient to demonstrate the use of the inhaler in front of the doctor, reinforce the technique, prescribe different type of inhaler if they can't get it right, or add a spacer device. I often use a PMDI with a spacer, or I get one of the family members involved. They can use a two-handed technique to actuate the PMDI and use a lever type device to trigger the MDI or the autohaler. Always retrain. Teach back methods can be incorporated. Use videos for training. In hospitalized patient, nebulizer therapy may be more appropriate, and follow up quite soon. What about the other problem, which is poor vision? We forget about this. Many of the elderly patients have deteriorating vision, and it's important to take this into consideration in every patient. And in this study, they mentioned the teach to goal method, which has been very effective. And as I mentioned earlier, many of these patients have a decreased peak inspiratory flow. The DPIs, like I said earlier on, need a certain optimal inspiratory flow rate. And it may be compromised due to age, may be compromised because of lung hyperinflation with the disadvantaged position of the diaphragm. Hypoxemia, muscle wasting, and like I said, the flattening of the diaphragm. You can measure the peak inspiratory flow rate with some newer device like the in-check dial, etc. And using that, you can then decide which device to use. And some of the DPI devices may need a second inhalation to make sure that they've taken in the full dose. Don't forget that. What about cognitive impairment in the elderly? Very important. I mean, they can sit there and nod their heads and but you'd go away thinking, well, they understand, they know how to use the device. Please make sure they demonstrate it. Review the steps frequently with the patient and use the caregivers and family as part of the team. Very importantly, which we forget as well, I mean, you prescribe a PMDI as a reliever, you prescribe a DPI as a controller or maintenance therapy, and then a third device. So the patient now has to remember how to use the different devices, how to vary his inspiratory flow with the PMDI versus the DPI, and it's very confusing, and you've got an elderly patient who doesn't quite understand the intricacies of all of this. And we talk about comparing molecules in clinical trials, and we forget the molecule's got to get to the lung first before it works. And I think it's important to keep stressing this to the patients. So the key messages I'd like to give is decide the best device with the patient. Ensure correct inhaler technique. Use a spacer when using an MDI. Prescribe inhalers by brand and rationalize inhaler devices. Don't use all different inhaler devices in the same patient. Recheck the inhaler technique often. And always remember medical history, comorbidities. These patients often have diabetes, hypertension, hyperlipidemia, coronary artery disease, and they're taking a multitude of different medications. Besides drug interactions, you need to understand the different types of devices. Use a device that the patient can use, and if you need multiple devices, try to prescribe similar devices that have similar techniques for your reliever and controller. Always follow up and work with a multidisciplinary team to ensure patients are getting the best care. Otherwise, we're going to end up with this. Thank you.
Well, thank you very much for a very, very nice talk. So if there are any questions in the audience?
Thank you very much for your lovely talk. It is a very, very important topic for all doctors. I'm a GP myself. And what do you think about, because you were talking about devices and all these kind of things, which is more than techniques than pure medical matters. What about the yoga therapy? What about the use of our proper, our normal, instead of doing things to promote the big pharma? What about the yoga therapy? I would like to know about it a little bit more.
Okay. Thanks, Yuva. It's a very difficult question to answer because I don't think there's any clinical trials, and you cannot do a placebo-controlled trial with yoga or any one of those modalities. So I don't think there's any easy answer. I'm sure there must be some benefit, but I don't know. I don't know if anyone else has the knowledge to answer that question.
I think to the point that Yuva is making is related to breathing techniques in COPD patients, particularly those with severe COPD, who experience dynamic hyperinflation with any effort or exercise. And apart from inhaler treatment, I think teaching them to use pursed lip breathing makes a big difference to their quality of life. And yoga, in a way, does that. I don't think you need a clinical trial. Yeah. I think we need to promote that in addition to using inhalers correctly.
Yeah.
Yes, to go in the sense of, there's a yoga therapy going on in this session.
Oh, yeah.
It will be, I think this afternoon, I think.
No, this morning, after
this morning,
the break.
Yes, after the break. So we'll talk about that.
Okay.
Yeah.
Well, a question about the difference. Have there been clinical trials on the nebulizers versus PMDI? What about the scientific data you may have on that?
Yes. I think the data has been mainly in asthma patients, as far as I understand. And in acute exacerbations, there is data to show that PMDI with spacer devices is as effective as using a nebulizer, and this would refer to the use of bronchodilators, inhaled bronchodilators. In COPD, I think if you have a patient who has poor inspiratory flow, poor coordination, and has problems with the hands, I mean, many of them develop osteoarthritis, and they have great difficulty activating a PMDI. And with the DPI, they can't really generate adequate inspiratory flow. And there I would, I've used often a PMDI with a spacer or a nebulizer. But, with the nebulizer, there's very limited medications that you can deliver. There's going to be a long-acting beta-2, perhaps long-acting muscarinic antagonist in time that can be nebulized. So you have more variety with using a PMDI with a spacer. Thank you.
Last question.
Thank you for this very nice speaking. I fully agree with you for the use of the spacer. What do you think of a spacer with a whistle?
Yes. Yeah.
Do you have it?
Yes. Well, look, I think it's useful, but the important aspects of the spacer is the volume, also whether it's I forget the word for it, static or zero static, or not. Also the care of this of the device, and then just to make sure the patient gets the full inspiration or the full dose in, they can either use one deep inhalation down to total lung capacity, or they could use 3 or 4 breaths of tidal breathing, depending on whether it has a single one-way valve or not. So it would be useful to tell the patient they've had their dose. Thank you.
Last question. Short and last question. Thank you.
Merci pour cette intervention. Chantal pourra peut-être traduire, je ne maîtrise pas parfaitement l'anglais.
Oui,
je voulais savoir s'il y a des études qui ont été faites concernant les pays en voie de développement. Quel est le rapport qualité, efficacité et prix entre les différents systèmes?
Donc là, c'est pas sur les techniques d'inhalation que tu poses ta question. Est-ce qu'il y a eu les mêmes études dans les pays en voie de développement?
Est-ce qu'il y a eu des études faites concernant le rapport coût, efficacité
D'accord. So she asking if in the published studies you are aware about studies showing the same results in low developing countries.
Low income.
Yeah. Regarding the error in devices and the cost efficacy ratio.
Yes, I think that's a very, very good question, very important question, because not only in terms of the type of device, but what's available and how the patients can go and get the devices. I think we have that problem back home as well, where either they have only PMDIs or they have only certain molecules available in the clinics, in the rural areas. And then patients can't get there because they don't have the transport or they can't afford the transport to get there. So I think that's a very important and very relevant question. I'm not sure if there are any studies. I don't know if there's anybody else here would like to answer that, in terms of low-income countries and the cost effectiveness of using PMDI versus DPI or other devices for that matter. I'm not sure. But just from off the top of my head, I know PMDIs are probably cheapest in terms of acquisition costs, especially the generic ones. But I have one problem with that, and that is when you take 2 drugs and they talk about bioequivalence, all right? They talk about the molecule. They're not talking about the actual molecule plus the carrier molecule plus the device. So it may not be as effective, clinically effective, as the original. So that is something that nobody has really published on. I haven't really seen that published. So it's a complex question with a complex answer, and I don't have the data or anything to answer it. So
yes,
I don't know if anyone else have that.
Perhaps it could be an idea for protocol or study in our different countries for the future.
Okay, thank you.
So thank you for your talk.
And Sab, the problem is that when we are doing our Congress, we are talking about devices, and so much things, and we are talking to the high world. We're never talking about this, the low world, if I can call it like this. And what we should do, the device is one thing, but what about prevention? What about prevention? I mean, this is the education, how to, if you don't smoke, then you won't have COPD. So the problem that we don't put accent on those, on this particular issue. And this must be something with, unfortunately we don't have something on tobacco. We should have this. But we should have tried to give emphasis on that problem.
Yes.
Prevention, it must be better than cure.
Oh yes, I mean, I think that's vitally important, self-explanatory, and I think one step further, we need to educate our politicians and our funders to make all these drugs available to the public. I mean, look at our, I can talk from personal experience, looking at state hospitals back home. It's only some of the big teaching hospitals that will have all the different drugs, and that too, not all. And Cape Town, I know, as a teaching hospital, they don't have access to a combination of a LABA and an ICS in the state hospital, leave alone the rural clinic. All you'll get in the rural clinic is, if they have stock, is either an inhaled corticosteroid or and a beta-2 agonist, and that's it. You've got to treat your COPD with a short-acting beta-2 agonist and an ICS, which is criminal.
And Umesh showed us that last time, when if you only put electricity, you reduce to 50%.
Yes.
This is and we don't do it. I mean, this is we must be political also when you are treating medicine.
Oh, absolutely.
Unfortunately, but this will be one of our tasks in the future.
Yes.
And pollution and so on, I think. Thank you.
Thank you.
Okay. Thank you very much.